So let me just give you some idea of what the real challenges are. In a way, just to expand on what Karim said, landing in Kinshasa is the easy part. Trying to get from Kinshasa to Bunia, which is somewhere in the order of around 3,000 kilometers away, so you can't drive there, you have to fly there. But the airport in Bunia is closed because it's the epicenter of the outbreak. And so with a closed airport, the only way to get from Kinshasa to Bunia is to actually take a United Nations Mercy flight, the humanitarian air services. And so that's what I do. Ironically, my flight number was Ebola.1 205H, which I thought was ironical given the reason I'm going into Ebola territory. When I got there, I went and visited several facilities, but I'll just describe one of them. This is one of the biggest hospitals, treatment facilities in Bunia. And this was the best of all of them. So when I show you this, none of the others are of this standard. The others are more, smaller district level facilities. So about half this hospital, called Evangelical, it actually was a missionary hospital before the government took it over. They've allocated 80 beds for Ebola patients in this hospital. And as you look at the hospital, at the picture on the right-hand side, you see those parallel sheets of white plastic. That's the area of the doffing of PPE. And I'll come back to that in a minute, but just for you to understand where it's located. So when you enter the hospital takes you through a whole lot of sections, the pharmacy section, the place where they are cooking food. By the way, this is the only hospital where they cook food for patients. Or almost all the other facilities, nobody cooks food for patients. The families are expected to bring food for their patients. But they do provide one meal a day at this particular hospital. And the red zone is demarcated as one half of the hospital with this white plastic sheet. And the sheet has a little transparent window with this chute through which they send all the food and medicines and clothes and so on. And you can imagine, in this kind of setting, this hospital has devoted half of all its facilities to Ebola. What is that doing to all of the other problems that they would normally see? Well, in the PPE donning room, I met these two healthcare workers, one a nurse and one a clinician, and both of them were busy putting on their PPE. And I asked them, are you hesitant or scared or concerned? None of the above. They just smiled and said, no, this is what they are here to do. And I didn't go in with them, but I watched them as they entered the facility. And this is the picture on the right-hand side is them entering one of the Ebola wards. But this is the real challenge. When they come out of the wards, they have to now remove their PPE. And that's a real problem because this person here sitting on the left-hand side in the left-hand picture is there to help them. And she will spray them down and help them take their PPE off. But their PPE is often quite heavily soiled from blood and so on, so it's quite infectious. And taking off their PPE is some challenge, and I'll show you this video so you get to see how they are taking off their PPE. And it really concerned me about the real challenges that they are facing in this kind of setting. The patients themselves, the patients are housed, the Ebola confirmed patients are housed in communal wards of 6 and 4 beds. And they have a section outside where patients can sit and visitors can come and attend and talk to the patients across this fence. They are not able to go beyond this fence, and there's a person who keeps an eye on this. But I felt that this was, being in isolation is quite challenging. And I spoke to 2 of the doctors who were in isolation. It really takes some doing. And to have visitors is quite important. So it is good to see that they've created that opportunity for them. And then at the same hospital, the big problem they have is that patients who come in with symptoms and signs, they are suspects, Ebola suspects, and they need to be tested. And it takes another day before you get the lab results. But in that time, the suspect can't be sent home and can't be put into a communal ward because you don't know whether this person has or doesn't have Ebola. So they have to be isolated in individual isolation wards. They don't have many of those at the hospital. The wards they have are communal wards. So the WHO was busy building these individual isolation wards, and they were doing so right into the night. And these are wards that are being built with wooden structure and plastic walls. So it's literally plastic sheeting that is demarcating each of these facilities. But you can see the challenge that they were facing because of this lack of having the facilities for single isolation. And then behind the hospital is the mortuary. And I won't go into this issue, but because when a patient dies from Ebola, the body is highly infectious because the viral load is quite high. And so we don't have much choice, but they put these bodies into body bags, which are dark black bags. And the patient and the families don't want that. They want to be able to see the face of in fact, they don't even know this is their family member. That's how challenging it is. So the point is that even burials are challenged in this setting. I want to just touch on, to end with, this problem of lab testing. So Bunia has a superb lab. This lab was just recently renovated by the World Bank. Actually, it was renovated for the Mpox epidemic because this was, a big area heavily affected by Mpox. And so they have excellent machine facilities, PPE, and so on. But the big problem they have is that the rapid test is what we need. We need to be able, when a patient walks in with symptoms, we need to be able to do a test there and then half an hour later say, you have Ebola, we admit you to the communal ward, or you don't have Ebola, you can go home. And that's what we can't do. So we're having to build all these individual facilities because we don't have these rapid tests. But there is a rapid test. It's made by a company in South Korea, but they don't have the machines available. And that's been the big bugbear that's been holding things up. So upon reflection, there are many things that are needed. But I thought I would I identify three of them. The first is more resources. So I went to one of the meetings where the African heads of states attended. It was very well attended. There were about 47 ministers of health of African countries. And there were several other countries represented there as well. The European Union was there, Japan was there. And at that meeting, many countries committed funds. For example, South Africa's president committed $5 million and so on. And it was at that meeting that I just saw how all the African countries were trying to commit something, even if they didn't have cash. They committed PPE or they committed personnel or they tried to do something. I really felt that was really quite important because it's telling the world and they're understanding that, we've got to do this together if we have to defeat this. If we don't, it's going to spread throughout Africa and indeed through the rest of the world. So they really need more resources. So they need everything from PPE to more wards, beds, and so on. They need a rapid diagnostic test, very high priority. The company itself that makes these rapid tests that do work has commissioned more machines so that we can locate them at each hospital. And just to explain the reason why the epidemic was so delayed in being reported, the patients were being seen, that were being diagnosed with Ebola. But when the bloods went to the lab was diagnosing them as negative on Ebola because the gene expert test, which is what they all use, the gene expert test doesn't pick up Bundibugyo strain in its Ebola cartridge. It only picks up the Zairian strain. So we lost about 2 weeks because the tests were coming back negative. It was only when they sent the bloods all the way through to Kinshasa And eventually, in fact, the initial lots that were sent on poorly, in very poor condition. So the second lot was sent on the 11th of May. That's when they did a full-length PCR that they were able to diagnose Bundi Busho. And then finally, we really need some electronic systems. All the data is managed on paper or on whiteboards and so on. I'll just end off with those that we're dealing with a major crisis. Perhaps just to say, the U.S. at this Ministers of Health meeting committed $300 million, and they did so I think through some other mechanism, probably through the DRC government. But we haven't seen any of those funds, and we haven't seen any of what they were supposed to do. But the big problem is logistics. Without USAID managing logistics. So, for example, IMC is there. They provide medical personnel. They couldn't see patients the day I was there because they don't have PPE. And because they're not part of IMT, they can't draw on the WHO's stock of PPE. So this whole thing is quite ridiculous that the US is not part and parcel of this overall response. And indeed, when you talk to people there, they talk about how all the countries in Africa have been coming together under the Africa CDC to deal with this problem. And the US response instead was about a travel ban, was about building a facility in Kenya to isolate its own citizens. So, their response has been the antithesis of what everyone else is doing. And I think it's just so people can have a sense of what is being said there.